webinar. My name is Kim Cervantes. I'm with the Regional Epidemiology Program here at the state. And if I can move my slide. Okay. So the purpose of these forums is basically to share information on communicable disease topics between the State Health Department, our local health department partners, hospitals, and others. And based on your feedback on our participant evaluations, we're continuing to hold these forums quarterly with in-person meetings in the spring and fall and webinars in the summer and winter. Based on the format feedback we had from the last webinar, participants thought it was a little too long, so you'll be glad to know we shortened the format a bit to 2 hours. So we're going to try to end right at 11:30 this morning. And the topics that were selected were also based on your evaluation, so we definitely appreciate your continued input. For credits, today's program is approved for 2 public health and 2 nursing contact hour credits. I will go over the details of how the credits will work at the end, but if you are watching the webinar as part of a group and are not physically logged on, you will need to complete a group sign-in sheet and provide that to me after the webinar. And again, I will give you details on how to do that. For questions, you can enter questions at any time into the question or chat box. We will answer questions at the end of each session and then also at the end of today's webinar. If we don't have time for all the questions, I will definitely get back to you after the webinar with the answer to those questions. The webinar will be recorded and posted online, and I'll show you where that will be located. And the presentation slides are posted on NJLMN under the Practice Exchange. So this is something a little bit new. It's kind of exciting, and we are now hosting the recorded Communicable Disease Forum webinars on the State Health Department website. So there's probably a couple ways of getting to the site, but how I get there is I go to the main health department page. You can see in the first graphic, I click on Public Health. It opens the orange screen. I click on Communicable Disease, which opens our main Communicable Disease page. And at the bottom right corner of that page, you can see a button that says CDS Training Resources. So if you click on that, it's sort of a bare bones page right now. We're working on the overall format and look, but the recorded webinars will be posted here in reverse chronological order. So probably within a week, today's program will be located on this website. So if you missed it or a colleague is interested in one of the topics, they can go and watch. One note, though, there will be no public health or nursing credits offered for watching the recorded webinar, just for the live webinar today. Okay, just a few quick notes. The Regional Epidemiology Program did send out a survey after our first quarter highlight report for January through March, and we received a lot of very good feedback. We are working on compiling that and making a few changes to the report. So again, we appreciate your input. And we've had a lot of requests from health officers for a simpler report on communicable disease activity. And we're working on that, and I'm going to show you what a screenshot of that will look like on the next slide. But as always, if you have specific communicable disease data needs or information you'd like for a report, I encourage you to discuss that with your regional EPI. So this is basically what the report will look like. Again, we're still working on the format, but at the top you can see I've blacked out the name of the local health department. So this would be local health department specific. And we'll give you a snapshot of the communicable disease reports that are coming in by quarter. So you'll be able to compare the number of reports for the current quarter as compared to the last quarter, as well as the same period in the previous year. So for example, looking at this slide, this particular health department, looking at Lyme disease, if you look at the right arrow, there were 5 reports of Lyme disease received during the second quarter of this year, or between April and June. Looking at the same period last year, which is where the left arrow is, there were 92 reports. So there's obviously been a very dramatic decrease in Lyme reports in 2015 compared to 2014. So this is something we might want to take a closer look at. But this is basic, the format of the report, and hopefully we'll be able to start sending those out to you on a quarterly basis in August. One note, though, this comes directly from CDRSS, so any CDRSS user can actually run these reports for their local jurisdictions. And again, if you'd like to do that, just let your regional epidemiologist know. All right, so these are our required nursing disclosure slides. Participants must attend the entire session in order to earn contact hour credits. Attendees must participate in all learning activities. Verification will be noted by attendance in the webinar or provision of that group sign-in sheet that I mentioned, and completion of the online evaluation. And again, I'll go over how that works at the end. Participants cannot miss more than 5 minutes from a 60-minute session, etc. The participants must complete the online program evaluation, and nurses must include name and email address, because that's how we'll send you your nursing certificate. No commercial support has influenced the planning or the educational objectives for today's event. No influential relationships have been disclosed from planners or presenters, and there's no endorsement of any product. Okay, so with that, I'm going to turn it over to Rebecca Greeley and Eric Warren. They're going to be talking about the steps involved in investigating a case of Legionella associated with a healthcare facility, either in a hospital or a long-term care setting. And with that, I will turn the screen over to Rebecca.
Hi everyone, my name is Rebecca Greeley. I am the infectious disease team coordinator and the subject matter expert for Legionella. My colleague Eric Warren will speak second. He will be talking more specifically about what needs to be done in terms of investigating once we've identified a building. So first, I'm just going to go over the organism itself. Legionella are ubiquitous in the natural and the artificial water environment. They tend to grow in warmer temperatures. So we tend to see problems surrounding hot tubs, cooling towers, hot water tanks, large plumbing systems, and decorative fountains. This organism grows best in warmer temperatures between 77 and 110. But what this means is actually it can still grow above 110. It just may not like those warmer temperatures. It's not usually killed until the temperature is about 124 degrees. And the organism actually goes dormant under 77 degrees. So if your water is colder, it doesn't actually kill the organism, but the organism goes into a dormant state where then if the environment was conducive to growth, it would then be able to grow. Legionella pneumophila serogroup 1 is what you will hear the most of in terms of cases. This organism causes the majority of human illness, but there are other serogroups that do cause human disease. This is a little schematic of what I would call the perfect storm that needs to happen in order to become a case of Legionnaire's disease. You first need the pathogen to be present, and the pathogen has to be able to grow or amplify. There's lots of ways that this can happen within a water system. There can be biofilms inside pipes. There can be protozoa where the organism is inside and able to grow. And then you get this environment that the organism likes. My colleague will talk about some of that later because some of that gets into the building problems. But not only does the organism have to be present, it then has to be able to be transmitted. So that's usually through an aerosol exposure, something like a shower, or some sort of a droplet of water that's in the air. And then that's not even enough. You then need a susceptible population. And so this is usually your immunely suppressed and your elderly. So that's kind of the picture that needs to all be in place in order for somebody to contract Legionnaire's disease. And not to confuse matters, but the term legionellosis actually covers two forms of this disease caused by the same organism. You usually hear about Legionnaire's disease because it's more severe. and people are more sick. But there's also the Pontiac fever form, so I was just going to go over these real quickly. So Legionnaires' disease actually has a low attack rate because it means that the organism has to be able to get into the lungs of a compromised person usually and actually put down roots and create an infection. However, there's a high mortality rate, and it's actually usually about 5 to 30%. It has a longer incubation period of 2 to 14 or 2 to 10 days. Usually people have a very high fever, they're very sick, they have difficulty breathing, they usually have a cough, chills, chest pain, and part of the case definition is also that they have pneumonia. These people almost 100% of the time end up in the hospital and even into the ICU. But Pontiac fever has a higher attack rate. However, it's more of like ILI symptoms or flu-like symptoms. It's self-limiting, it's muscle aches, it's maybe a little bit of a fever, it's a much shorter incubation period, and people are not dying from Pontiac fever. The tricky thing with this is these cases are not usually detected because you would not go see your doctor if you experience these symptoms. We do catch Pontiac fever cases in the presence of more of an outbreak where we are looking for other cases of it. Pontiac fever is more of the body's reaction to coming into contact with the organism. So this is reportable, and together they are both called legionellosis, but for the remainder of my talk I will mostly be referring to Legionnaire's disease, the more rare but more severe form of the disease. So who is at risk for legionellosis? So usually healthy individuals do not become infected. However, the people that are at higher risk of becoming sick are elderly individuals, former and current smokers, people who have chronic lung disease, COPD, asthma. We see a lot of cases, unfortunately, in the younger people who have cancer, so they have a weakened immune system. We see a lot of people that have kidney issues that become cases that are on dialysis, people that have diabetes. And also you have to worry about people that are at risk for aspirating and having problems swallowing, because if they were swallowing water that had the organism in it and then aspirated, that's another way that the organism can get in somebody's lungs. So who to test? This is more of maybe a clinician thing, but I wanted to present this. So who are the people that maybe legionellosis should be on the radar? Patients who failed outpatient antibiotic therapy may be considered to be tested. Patients that have severe pneumonia, specifically in those that require intensive care, we would like all emergency departments to be testing all people that come in with a pneumonia, community-acquired pneumonia, or hospital or healthcare-acquired pneumonia to be tested for Legionnaire's disease. Immunely compromised people with pneumonia should always be tested. Obviously, people that were involved maybe in an outbreak. People that have a travel history, there's a travel component to people being exposed to Legionella. And people, obviously, that come from another healthcare setting that have pneumonia and were not part of the community. These are all people that should be on the radar to be tested. The good thing about this disease is that it's not spread person to person. So we don't normally see outbreaks that have a lot of cases because it has to be that perfect storm picture for somebody to become a case. So the public health investigations and surveillance rationale, we want to monitor and describe the incident and trends of these legionellosis cases. We want to look at cases quickly. We're looking for locations with or people that have similar exposures. Some of this is travel, some of this may be a healthcare. Most of our cases, I would say 80% of our cases are what's called community onset, and we don't really tie them to a building. But that's all part of our public health investigation, is really trying to seek out where these people may have been exposed and to put in control and prevention measures. Just real quickly, the case definition, and this is on the chapter, and this is within CDRSS. I didn't want to spend a lot of time on this, but I'm only taking a piece of the case definition because this is the one that I ask you guys to get more involved in. A confirmed case of Legionnaire's disease is somebody who has fever, myalgia, cough, and a clinical or radiographic pneumonia. Laboratory-wise, there's 3 ways to have a confirmed case, but the most common one has the arrow near it. You will see this urinary antigen done. This is more of a rapid test that the results come back quickly, and so clinically it's the most useful. There are limitations with that because that only tests for Legionella pneumophila serogroup 1. There are other ways to become a confirmed case. The first one that's there says by culture. This is the isolation of any Legionella organism from a respiratory, lung, or other sterile site. These hardly ever happen because Legionella takes about 2 weeks to culture out. So again, clinically, patients in the hospital, it doesn't make a lot of sense to culture for Legionella. The other thing is they would have to specifically request that the culture be tested for Legionella because it has special requirements to grow. The other way to become a confirmed case is by seroconversion, which is a 4-fold rise or greater in titer. These do not help much in detecting cases because we usually get single antibody tests, and they are not helpful for confirming a case. The rest of the case definitions, I would ask you to look up your chapter, but the one thing I wanted to point out, there's no probable case definition. You are either confirmed or it's suspect, and the suspects get into the different other forms of seroconversion. Mostly you will either be working on a confirmed case or not a case. So these cases are coming in from labs, from doctors into CDRSS, like every other reportable disease. We ask the local health departments perform disease investigations into each of these for their residents. We are looking for illness onset date, an incubation period, potential exposures that include water. These include maybe if the patient's a long-term care resident, has overnight travel, anything like decorative fountains, if they're using a nebulizer. These are all listed in the risk factors within CDRSS. So for every case that comes in to CDRSS, we ask that you get these bare minimum data. So when it starts to move into a healthcare setting, with Legionnaire's disease specifically, we consider this more of a perfect partnership. So a lot of these people, like I said, the majority are hospitalized and even in the ICU. So as these patients are in the acute care setting, we can already start those case investigations, and that acute care hospital is a key player in this case investigation. And a lot of times we ask that the IP, the infection preventionists at the hospital, are contacted to get the information because the patient's there. We also get a lot of information from the intake form as the patients are either in the ED or they're in the ICU. We're looking for onset date, fever, things like that are easily attained with the data that's at the acute care hospital. The other partner in this is whether they were at a long-term care. So we're looking with residents that had pneumonia, and these turn into building investigations, which is where we will spend the rest of the time with this presentation. So these initial steps of a long-term care investigation, the case comes into CDRSS. We quickly find out that the case is a long-term care resident. That one confirmed case in a long-term care is considered an outbreak. So the next 3 bullets are the 3 pieces of information that we are going to ask for you up front. And I usually have your regional EPIs reach out to the local health departments to really firm up, number 1, whether the person really does meet the confirmed case definition. Did they have fever? Did they have pneumonia, cough, myalgia? And then the appropriate lab, which is usually the urinary antigen. Number 2, we're going to ask for you to establish an illness onset date. So that usually is the fever. So a lot of times these patients come to the emergency department, and in the emergency department notes it says, patient has 2 days of fever and now presents with respiratory distress. That 2 days of fever, we would go back those 2 days of the fever onset, and we can use that as your illness onset date. The reason why it's important to establish that illness onset date is because it dictates the incubation period. So then the third piece of information that we need when it's a long-term care or a person that has only been in a healthcare setting, like an acute care setting, we want you to confirm that they were only in that healthcare facility during that incubation period. So first you need to confirm their case. Second, you need to determine their onset and their incubation period. And third, we want to determine whether they truly were in that facility for their incubation period. So once those 3 pieces are established, it quickly turns into an investigation with 1 case. So with this, as the investigation continues, we are going to have an E number or an outbreak number generated, and that's usually through your regional EPI. Then we are quickly going to want you to set up a conference call with the facility. So that includes representatives from NJDOH Epidemiology, that's the local health department, and that's the facility. So these are the 3 big entities that will be on that initial conference call. From the facility, we would ask that the facility administrators are on the phone. They're the ones that are usually able to make the big decisions when it comes to their facility. We're going to want their director of nursing on the phone, their infection preventionist if they have one, and also the facilities manager and whoever would be in charge of maintenance, because we're going to ask questions on the patient, and we're going to ask questions about the building. So some of the initial information that comes out on that conference call is having the patient's chart in front of them. If it's a long-term care person, we're going to ask about all of their exposures in those 2 weeks leading up to their illness onset. We want to know about nebulizer use, any kind of oxygen use. Are they at risk of aspiration? We want to know all possible exposures of water with that case. Did they shower? Do they normally take baths? And then the building itself, the age, the size, the number of outlets, and my colleague Eric will be getting into that in a moment. We also want to know, is there a decorative fountain? Some of these healthcare settings or long-term care settings, they may have a decorative fountain that residents like to go sit near. That could be a clear risk to patients if it's not well maintained. So some of the immediate actions that we would ask the facility to take, and these actions would be talked about on that initial phone call that I referred to on the last slide. Some of the immediate actions would include shower filters, which is a little picture at the bottom, shows two kinds of filters. A filter that would go on the end of a handheld shower, which is called point of use filters, and the other two in that picture are called inline filters. That is something that would go more behind the wall in the line of the plumbing to filter out the water before it would reach the residence. So along with the shower filter recommendations that we would put in place, we would ask that they would offer bottled drinking water to any residents that would be at high risk for aspirating. And we would also ask that they remove the aerators from the sinks, because the aerators create a fine mist particle in the hand washing sinks that creates an increased risk of an air particle if it was contaminated, to be exposing a resident or a worker at the building. The next immediate action that we would recommend to the facility is to hire a water consultant, and not just any water consultant. We would ask that they hire a water consultant that has experience in controlling Legionella or Legionella in a big building system. Along with hiring that water consultant, we would ask that a walkthrough of that building and an initial meeting be scheduled. And that walkthrough building, we want the same people represented. We would want that consultant, obviously the facility because we're there, the local health department, and the New Jersey Department of Health represented at this meeting, so everybody is getting the same information and is on the same page at the same time. We also would ask on this initial phone call for ongoing surveillance of other clinical cases of pneumonia or respiratory distress. Now, this is an important one because most of the emphasis with these investigations quickly turns into the building, but we can't have the director of nursing or the infection preventionist forget that we're really looking for other cases of human illness in case they really do have a larger outbreak that's going on. Anybody who has a pneumonia or respiratory distress or is sent out for those symptoms needs to be tested by urinary antigen for Legionella. We're going to ask that they're doing some initial water sampling and culturing for Legionella, and then we would be moving into a remediation and then follow-up testing. So with that, I will hand it over and to talk about more of the specifics with the building investigation.
Good morning. After they've hired their consultant, and we always recommend that the consultant, as Rebecca said, has experience with Legionella. A lot of people will hire a consultant that really is trying to sell them a continuous secondary disinfectant system. That's not the right type of consultant. We've scheduled the walkthrough. Facility management needs to be there from at least the building standpoint. And if they have an outside plumber, we would prefer to have the outside plumber there because we're going to be talking a lot about the plumbing system. Obviously, we want the consultant there and then the local and state departments of health. We will always be recommending pre-sampling for Legionella, and we will always be recommending that they be ready to start a plan for the remediation and follow-up. What causes Legionella, and why are we looking specifically at long-term care facilities and hospitals? I'm going to say long-term care facilities, from my experience, are about 90% of the buildings that I've been investigating. We get the hospital maybe another 5% of the time, and we've looked at hotels, but pretty much 95% is going to be hospitals. I mean, hospital or healthcare facilities, long-term care, acute care. Temperatures, 80 to 110 may be the optimum, but it will actually live and grow quite nicely from 68 degrees all the way up to 122. Water stagnation is something that helps very much in the growth. Water that has a lot of sediment and scale forming in the plumbing is going to provide a lot more food than you might find in, a cleaner water system. There's a symbiotic relationship with amoeba, protozoa, and algae, which are the, shall we say, backbone of biofilm, which you'll hear about when you're involved with the Legionella investigation. Some parts in the plumbing systems also support the growth. Rubber and some plastics are good food for the Legionella. We're going to look at the age, size, construction, room configuration, how many outlets in each room. Obviously, if there's a sink and a shower in each room, there's a lot more likelihood of some kind of exposure. We want to know about the renovation history. If they've been doing work on the pipes, that very often causes the biofilm to break away and then release its package of Legionella into the water system. And you happen to have somebody showering at that moment, and they get exposed. The design of the plumbing system is obviously important. Most large buildings will have some kind of recirculating system for at least the hot water, so that the hot water, people don't have to wait for something on the for the hot water in the basement to get all the way up to some room in the 5th floor. We also look at the heating and cooling system. The original Legionella outbreak was associated with a cooling tower that was cooling a hotel in Philadelphia. And then the cooling tower was producing a mist with high levels of Legionella, which were being drawn back into the building through the makeup air system. We also want to know what their regular occupancy rate is. Buildings, hospitals, and long-term care facilities that have a lot of rooms that are not being used, those are areas where the water is going to be stagnant and areas where the Legionella is going to grow. The water condition as it's supplied is part of the building assessment. What's the residual chlorine in the water coming in from the potable water supplier? What's the temperature? If that temperature is getting above 70, 75 because it's a surface water source, that may be a cause of more Legionella being in the supplied water. Do they use hot tubs, spas? Again, decorative fountains, all can be areas where the Legionella can grow. Cooling towers, we'll look to see if they have any of those. Even air conditioning drip pans have occasionally been associated with the potential for Legionella to become airborne. Recent and ongoing construction in the building, and also repair or construction on the outdoor public water system. If they are putting in new pipes in the water supply system, those things might increase the amount of sediment or the amount of bacteria that's in the water. What are the sources of exposure? Where can you breathe this? That's why we look at showers most often. People taking a shower are apt to breathe in the mist coming off of the shower. And you have to remember, the water in long-term care and hospitals, at least in the patient areas, are kept at 120 or less, pretty close to the optimum temperature for the growth of Legionella. Cooling tower mist, as I said, that was the original Legionella outbreak. Aerators on faucets may increase the amount of mist in the air. Nebulizers, obvious source if they're cleaning the nebulizer with water from the potable water system instead of sterile water. Spas, whirlpools. The other source is aspiration. Ice machines have been associated with Legionella. The ice, even though it's below freezing, the Legionella, if it gets into the ice machine, is not killed at that temperature. So drinking and then aspiration can cause legionellosis. Also eating food, as long as it's not cooked, made with tap water. Plumbing systems, where do you get some of the risks there? Well, sediment might build up in tanks. Oftentimes we've recommended instant heat, so there is no tank where the water is being held, but there are certain problems associated with that. Also within tanks, particularly tanks that are vertical, the temperature stratifies, so you might have 120 up at the top of the tank, and then 110 or less even near the bottom of the tank where the sediment is and where the Legionella might be growing. Dead leg. So dead leg is any capped off part of the plumbing. So you have a renovation, they decide to take out a bathroom, and then instead of cutting the plumbing all the way back to the still active line, they leave a little stem 6 or 8 inches so that they can, reestablish a bathroom there when they want to. Well, that's a dead leg. That's water in there is stagnant. That's where you'll get a nice growth of biofilm. Also, that'll again be symbiotic with the Legionella. Unused rooms are what I call are operational dead legs. Yes, they still exist. Yes, the water still flows through certain portions, but they have major long runs of plumbing that are just stagnant because the room is not being used. And again, rubber gaskets are oftentimes used. Expansion tanks that are seeming to be taken out now more often also have rubber lining that might be food for Legionella. Generally speaking, water temperatures coming in from the street are going to be have low chlorine levels, and water temperatures maybe just below the optimum temperature, but not at a temperature that would keep the Legionella or kill the Legionella. We always recommend pre-remediation sampling. Oftentimes we get the question from the administration of the hospital or long-term care facility, well, if it comes back negative, we're okay. And the answer is no. We have the ultimate sampler, that person that came down with Legionella associated with your building, is an indication that you have it in your water system. One sampling run or sampling cycle is not going to automatically show that just because it's negative that all of the lines are negative. We also recommend a CDC certified elite laboratory. This is a certification program where the lab shows CDC with unknown amounts of Legionella being tested, sent from CDC, that they can both identify and speciate the Legionella. We also recommend the sample be an entire liter and that all of that water be processed. Certain labs have decided that they can do with 100 milliliter or 200 milliliter, but we recommend, in this case, going with a full liter. We want to test approximately 10% of all the outlets. Usually we will include the room or rooms associated with the case and a room most distant from the case room. And then of the rest of that 10% should be located in various parts of the building, randomly selected. We will also include all tanks. We will want hot water returns. The reason for hot water returns, this is probably the coldest part of the hot water system. The water has gone up into the building, cooled over time, and now it's coming back to be reheated. That temperature in that part of the building can be a very high or low temperature place for high growth of the Legionella. And we usually, for pre-remediation, also want to know what the supply water Legionella levels are, plus temperature and residual chlorine. There are no known safe levels of Legionella. The OSHA technical document has certain recommendations, but you need to remember that those recommendations apply to a workplace where you have a healthy population, not a long-term care facility where you have a very susceptible population. So basically, we shoot for what we call, for those who know radiation, a LERA, as low as reasonably achievable. If the levels come back and are detectable but not high, if 30% of the samples have a detectable but not high level, we're going to want to assess the, if less than 30% come back that way, we are going to want to assess the system to see if preventive maintenance and other types of changes to how we're operating the system can be done. If we get over 10% of detectable but not high levels, we're going to very often recommend another remediation. And if we get a line with greater than 1 colony-forming unit per milliliter, we're going to recommend at least local remediation of that line. The two most common ways of remediation or emergency remediation is superheating or hyperchlorination. This is getting the water up to greater than 160 degrees Fahrenheit, or chlorine levels up above 50 parts per million for 12 to 16 hours. We also have recommend hourly sampling at every single outlet to make sure that those levels of heat at 160, chlorine at 50 are maintained throughout the contact period. Obviously, this causes significant patient safety issues, because if a patient wakes up in the middle of the night and goes to the bathroom and turns on the hot water, 160 degrees would cause instant scalding. After we've done a remediation, we also want follow-up sampling. Because of the upset period immediately after remediation, we start by sampling every 2 weeks for 3 months, and then monthly for 3 months, and quarterly for another 1.5 years. So 2 full years of post-remediation sampling. We recommend continuing the sampling at a maybe lower number of samples and for, maybe every 6 months, but after that, that's simply recommending for safety purposes. After each sampling cycle, we assess what we have, and again, the number less than 30% with barely detectable levels, we might check the preventive maintenance system, but higher levels or greater percentage, we're going to start looking at the possibility of re-remediation. If samples keep coming back at the same location with non-detection, we may move those samples to other locations, but we try to stay up with about the 10% of all samples. So we don't reduce the number of samples over this period in most cases. We want the local health department to be in communication with the facility to make sure that these things are happening and that the data is sent to them and to us. In some cases, we might recommend looking into a secondary disinfectant system. Most of them have to do with chlorination of some kind, chlorine dioxide, or chlorine monochloramine. The problem with these are they can be very hard on the plumbing system. They also produce certain byproducts that are associated with adverse health effects. Copper silver is another one that's commonly used, but we are seeing cases where there seems to be the growth of some kind of ability of the Legionella to resist the copper-silver ion. The advantage of these, though, is that these chemicals do move around throughout the system. They kill the biofilm and they kill the Legionella. Also, though, there's heat, ozone, and UV light. The problem with each of these is the heat is usually just in the tank where the water is heated to 140 or more degrees, or where the ozonation occurs, or where the UV light is. These do not circulate throughout the whole system at disinfecting levels. What our hope is for the local health department is that they maintain communication with the facility, that they assure that sampling results are distributed to themselves and to the state health department, and that they schedule any conference calls and have frequent contact with the facility. Also, the CDC case report form is filled out and again sent to all the appropriate people.
Okay, thank you, Rebecca and Eric. Again, if anyone has a question, you can type it into the question box anytime during today's webinar. We did have one question concerning the sampling and the 1 liter amount. Is that 1 liter per sampling outlet or 1 liter total?
That is 1 liter per sample, so per outlet. So if you have 30 outlets that you're sampling, you will have 30 liters sent to the elite lab.
Okay. All right, thank you very much. With that, we're going to move to today's hot topic presentation. Lisa McHugh is going to give an update on both MERS-CoV and Avian.
Thanks, Kim, and good morning, everybody. So we'll move on into our presentation. So this morning I'm going to give an update on viral respiratory pathogens, and that will include avian influenza and MERS, or Middle East Respiratory Syndrome. So I wanted to just provide a brief background on influenza viruses just to make sure that everybody, we're all on the same page and talking about the same thing. Again, influenza has 3 different types of viruses. Type A, which can infect humans and a variety of other animals, including birds, pigs, and horses. Actually, wild birds are the natural reservoir for influenza type A viruses, and these type A viruses also present the greatest risk for epidemics and pandemics. Type B viruses are, humans are the only known reservoir for these, and we do have epidemics of influenza type B viruses, but they have not been known to cause pandemics in the past. And there's also type C viruses, which we don't hear a whole lot about. Humans and swine are the known reservoirs for these, and these usually cause mild illnesses in humans without seasonality. And in any typical influenza season, we typically see 2 influenza A viruses circulating, usually 1 type H1, 1 type H3, and then 2 different B viruses circulate in the 2 different lineages, usually with 1 predominating. Again, we're going to focus primarily on the concern with influenza A viruses, which have the ability to undergo what's called antigenic shift. This antigenic shift results in a major change, resulting in a new subtype or a novel influenza virus. Both A and B viruses also can change minimally over time. This is what's called drift, and this particular process occurs continuously which is why we need a new influenza vaccine each and every year. And while drifting can be very concerning for vaccine mismatches, as what happened in the 2014-15 season, it's less concerning from a global pandemic perspective. So novel influenza viruses happen when an influenza A virus shifts to the extent that it creates a genetically unique virus and that humans lack pre-existing immunity to, and that's why this virus is called novel. These influenza human infections are different than what is currently circulating in a typical influenza season. Currently, that would be influenza A H1 and influenza A H3. Human infections with novel viruses are transmissible person to person and may be the signal of the beginning of a pandemic. So just as a reminder, in order for us to have a pandemic influenza virus, we require 3 different factors. The first is for the ability of that virus to replicate in humans and cause severe illness with a very high mortality. We must have a population that's immunologically naive to the human population, i.e. that novel influenza virus. And then we also need efficient human-to-human transmission of that virus in order to have a pandemic. So because the signal of these novel influenza viruses can be the indicator of a pandemic approaching, novel influenza viruses were made reportable in June of 2007 and added to the nationally notifiable disease list. Since that time, several novel influenzas have been under surveillance, and I'm not going to mention them here, but they are listed on the slide. And I'm specifically going to talk about the most recent occurrence of what they've deemed H5N1 avian influenza. So just a brief review on avian influenza viruses. Again, novel influenza viruses are avian influenza viruses, as the majority of avian influenza viruses are found in animals and not necessarily in humans. Avian influenza viruses are type A viruses, and again, that natural reservoir is in wild waterfowl. These birds can carry the influenza virus in their respiratory tract and intestines. They do not usually cause illness in wild birds, but may cause severe illness in domesticated birds, such as poultry. They can survive at low temperatures and low humidity for days to weeks, and they can also survive in water. Avian influenza viruses are broken down into 2 different types, low pathogenic and highly pathogenic avian influenza viruses. Both have the ability to cause disease in humans. In the actual bird populations, low pathogenic avian influenza does not cause illness in wild birds, but may cause mild illness in poultry. It can be the cause of poultry outbreaks worldwide and can evolve into high-path avian influenza. Highly pathogenic avian influenza usually does not cause illness in those wild birds, but usually causes severe illness and high mortality in domestic poultry, and many of the examples that we've seen in the past have been associated with influenza H5 and influenza H7. So let's talk a little bit about high-path avian influenza H5N1. And the reason that it's X is that there's been multiple neuraminidase that have been identified associated with the current avian influenza virus. These detections began around December 2014 and have been predominantly H5N2, which has occurred predominantly in the turkey populations, H5N8, and H5N1, and that's the non-Asian lineage. And that's just to make the distinction that this is not the same virus that has been circulating in Southeast Asia since 2005. So there is a connotation of saying that it's the non-Asian lineage. These viruses have been detected in 21 states along the Pacific, Central, and Mississippi flyways. In 15 states, they've been found in domestic poultry and captive birds and created outbreaks in those states. And 6 states have had detections only in their wild bird populations. To date, New Jersey has not been impacted, and no human illness has been detected in any of the states with outbreaks. So this is a map from the USDA, and here you can see the different states that have been impacted with the poultry that has been impacted in findings. There have been 223 detections and nearly 48 million birds impacted, with the first detected around December and the last in June. So let's talk a little bit about what the response is to these outbreaks that occur. First, we'll talk a little bit about the outbreaks that occur when there's illness in animals. Predominantly, the USDA, and in our case, the New Jersey Department of Agriculture, would be the lead agency. The United States has one of the strongest avian influenza surveillance programs in the world, and that's predominantly to keep our food supply safe. The USDA looks actively for the disease and also provides compensation to affected producers, which also helps to encourage reporting from illness in their flocks. When there's outbreaks that occur in individuals, there's a number of steps that occur within the outbreak response in those animals. The first is via quarantine, which restricts the movement of poultry and poultry moving equipment into and out of specific control areas. There's eradication, which involves humanely euthanizing the affected flocks. There's monitoring that occurs within the region, both testing of wild and domestic birds in broad areas around the specified quarantine area. There's disinfection, which helps to kill the virus in the affected flock locations. And finally, testing to confirm that the poultry farm is free of avian influenza. Once an outbreak is identified or confirmed, you can see that zones are created around the actual affected premise. The infected premise is followed by an infected zone, a buffer zone, a vaccination zone, and a surveillance zone. In these inner rings is actually where the depopulation of the impacted birds results. The type of depopulation is dependent upon the type of poultry that's in the actual farm. This can involve layers, which are those chickens that produce eggs, or broilers, those animals that are used for meat, or turkeys. Broilers and turkeys are floor rearing, and therefore often foam that's water-based and used for fire suppression is used to euthanize the floor-reared animals. CO gas is often used for the layers who are stacked in cages. And then there's surveillance and prevention of the outer rings within this particular response area. There's establishment of control zones to prevent the spread, so any equipment or people that are going in and out of these zones are disinfected before they reach the outer zones to prevent contamination of other facilities and farm areas in that jurisdiction. There's also on-site composting and burial, which is currently recommended. And composting involves decomposition of the animals either on the property or in the actual house, which provides 2 heat cycles to that compost, which actually kills the virus on-site and allows for safe disposal and no risk to other flocks in the area as the animals are transported for burial. So what is the response from a public health standpoint? Well, once we have any illness in humans, and again, as I mentioned, there has been none to date, the CDC and the New Jersey Department of Health would become the lead agency for those human illnesses. This would involve us being responsible for reporting and testing of ill individuals, and again, those individuals are likely those that are associated with the infected flocks. We would be responsible for monitoring any individuals that are exposed to those infected animals. This would be within 10 days of the last exposure. And at this current time, the type of monitoring that might be used is currently being evaluated. The administration of antiviral post-exposure prophylaxis to anyone involved with the exposure of those animals, regardless of the risk, is also being recommended. So as far as public health guidance, in the current situation, the risk to the general public is considered low. The highest risk is to those who are working on those impacted farms and any of the outbreak response workers that are being called to help with the depopulation of the actual flocks. The same reporting and testing criteria as other novel influenza viruses also applies here. It's really looking for influenza-like illness plus exposure to those animals that may have been impacted. Antivirals are also, again, being recommended for those workers, both as treatment and post-exposure prophylaxis. So I'll move on to the other interesting respiratory disease that we've actually is not very new to us as a hot topic, but there have been some new outbreaks that have occurred that I'd like to talk briefly about. So the Middle East Respiratory Syndrome virus, MERS-CoV, is part of a coronavirus. Coronaviruses in general are common viruses that can cause mild to moderate upper respiratory tract infections, similar to the common cold. They can be associated with GI illness as well. Coronaviruses were the cause of SARS, or severe acute respiratory syndrome, that occurred a number of years ago. And incubation periods are typically tend to be longer than the common cold, and they usually circulate in the winter and the spring. Coronaviruses are prevalent in humans and domestic animals and can be found in cats and dogs and birds. The SARS virus was believed to be a novel coronavirus that had originated from civet cats. The current novel coronavirus, MERS-CoV, is believed to have originated in bats, although there have been other animal sources that have been implicated in its spread. MERS was first identified in April 2012 with the initial circulation found in the Arabian Peninsula, Jordan, Saudi Arabia, and Qatar. The case count as of July 17th has been 1,368 cases and 490 deaths, with multiple travel-related cases into other countries that have originated from the Arabian Peninsula. There have been clusters with person-to-person spread that have been documented but have not been sustained. The following is a current map as of July 20th of confirmed cases of MERS within different regions of the globe. Here you can see at the bottom right are the countries in and around the Arabian Peninsula that have had MERS cases that have been detected. And the second bullet involves those countries that have travel-associated cases, meaning they've had confirmed cases in their countries, but they've been related to those countries in the top of that list. You can see that Saudi Arabia has the highest number of confirmed cases, with Iran, United Arab Emirates, Qatar, and Oman quickly following. So let's talk briefly about the epidemiology. So MERS-CoV can create asymptomatic to severe presentation. The common signs and symptoms include fever, chills, rigors, headache, non-productive cough, dyspnea, and myalgia. Other symptoms include sore throat, coryza, nausea, vomiting, dizziness, sputum production, diarrhea, vomiting, and abdominal pain. Atypical presentations including mild respiratory illness without fever and diarrheal illness preceding development of pneumonia have also been reported. Patients who progress to requiring admission to an intensive care unit often have a history of febrile upper respiratory tract illness with a progression to pneumonia within about a week of onset. The majority of these cases have occurred in adults with a median age of about 50 years. They have been most commonly associated with chronic comorbidities, and the current case fatality rate is approximately 35%. The incubation period with MERS-CoV is thought to be about 5 days with a range of about 2 to 14, and the infectious period is thought to at least be while the patient is symptomatic, but may be as long as 3 weeks. There have been some studies that have been performed on specimens prior to symptom development that indicate that there is likely not shedding prior to the development of symptoms in cases. Asymptomatic cases have been identified among healthcare workers and children, predominantly those who had significant contact with confirmed cases. So the surveillance criteria is not really new, and we'll talk about that in the next few slides, some of the changes that have occurred in the surveillance criteria. But essentially, anybody thought to meet a MERS case definition needs to have both clinical and epidemiologic criteria. This involves having both a fever and a clinically confirmed pneumonia or some type of acute respiratory distress, a travel history to one of the affected countries, close contact with a confirmed or suspect case, or a history of working in a healthcare facility in one of those impacted countries. And in this particular last bullet, often we don't look, we look at a lesser symptom set for these individuals. So if they have a very high-risk condition, meeting fever and pneumonia may not be required in order for that person to be considered as a suspect case. So I realize that this is a lot of words for one particular slide, and I don't expect anybody to really read the small language on it. I do want to point out that this is directly excerpted from our guidance document that is found on our website, and that's at the very bottom of the page. So you can certainly access this guidance by going to that website. What I do want to point out is the addition of the particular language stating that we've added to the existing MERS definition the history of being in a healthcare facility as a patient, worker, or visit in the Republic of Korea within 14 days before symptom onset. This is the second part of that surveillance criteria, and again, I'm not going to go into it in great detail, but feel free to visit that website and look at the entire guidance document. So let's talk a little bit about that situation in the Republic of Korea that actually led to the addition of that to our surveillance case definition. In May 2015, there was a case identified by the World Health Organization of MERS-CoV in the Republic of Korea. This case was the first case and occurred in a 68-year-old national of the Republic of Korea with a history of travel to 4 countries in the Middle East. The case was asymptomatic during the return flight to the Republic of Korea, but on May 11th developed symptoms and subsequently sought care at 2 outpatient facilities and 2 hospitals, creating multiple opportunities for exposure among healthcare workers, patients, and visitors. Contact tracing was conducted and identified and evaluated individuals that were exposed to that contact case. Lab confirmed cases were also identified, including one that traveled against medical advice to China. He became symptomatic and was subsequently confirmed as a MERS case within China. As of July 21st, 186 laboratory confirmed cases and 35 deaths have been reported. And to date, all cases, excluding the index case, have been linked to a single chain of transmission and were all associated with healthcare facilities. This is an epi curve showing the confirmed cases of MERS-CoV associated with both the Republic of Korea and the China case that was associated via travel. Here you can see the last onset date of July 2nd. That has been the last case that has been associated with this outbreak in the Republic of Korea. Korea has implemented very strict contact tracing and also quarantine associated with that contact tracing for individuals who were found to be exposed. This is an article that was published in Neurosurveillance, and it talks about the 119 cases identified as having contact with those confirmed cases prior to illness onset. Of the 27 secondary cases in a single hospital, they've all been traced back to the primary case. Cases 14 and 16 led to a secondary wave of outbreak by infecting 73 and 23 cases respectively. This was followed by the initial outbreak generated by the primary case in Hospital B. In particular, case 14 infected at least 70 cases between May 27th and 29th while being treated in an emergency room in Hospital D, one of the 5 largest hospitals in Seoul, Korea, with multiple healthcare professionals and outpatient visits per day. According to the Hospital D, at least 893 patients and visitors were potentially exposed during this period, which explains the significant number of confirmed cases that have resulted in this particular exposure. There have also been 4th generations of cases confirmed, and with 10 or more potential 4th case generations being reported. So you can see here that this single individual case resulted in a number of different exposures. There have been some speculations that the culture in Korea is one of the 2 criteria which may have led to this prolific generation. The first is that of hospital shopping or doctor shopping, where patients will actually go to multiple healthcare facilities before they actually identify where they'll actually be cared for. The second thing that has been identified that may have potentially contributed to this is that there's a lot of family and hired caregivers who are not medically trained individuals that are hired by the family or the family members to actually provide direct patient care in addition to the hospital staff. These individuals would not necessarily be specifically trained in infection control practices while caring for these individuals. So this is the epi curve of the global confirmed case counts as of July 20th. And here you can see the distinct peaks. There's still question whether this is actually associated with some type of seasonality of the MERS-CoV virus, or if these are just waves that are associated with large healthcare facility outbreaks that are occurring within the countries. So I'd like to just talk about some of the common issues and concerns that we have had. New Jersey has had approximately 28 or 30 suspect cases that have been reported to us that we've worked up, and they've all been negative to date. But these are some of the common concerns that we find that are associated with these investigations as they occur. So first, I'd like to just talk briefly about laboratory testing. I just want to reiterate that the State Public Health Lab can conduct the testing. Our initial 3 specimens that we will request from you on any suspect case is an NP-OP swab, sputum, and serum. These, again, are an upper respiratory specimen, a lower respiratory specimen, and a serum sample. These are based on CDC recommendations, and the collection of these specimens can be found in a guidance document on the CDC website, and there's also a link in our guidance that's posted to the NJDOH website. There are other specimens such as stool and serology that can also be performed, and the decisions to collect these will be made on a case-by-case basis. The priority of the testing that's assigned is also assigned on a case-by-case basis. We can usually get results from the State Public Health Lab in about 6 to 8 hours after the receipt of the specimen at the State Public Health Lab, and then the priority testing is either to keep someone in the lab during the day or after hours to conduct that testing, or conduct the testing on the next business day, and that's based on a set of criteria that has been developed with the State Public Health Lab. One of our major hurdles in getting this is actually getting specimens transported to the State Public Health Lab, as this has been challenging. Again, as we'll see in the next couple of slides, these individuals, once reported, are asked to be put on airborne isolation precautions, and often they are hospitalized. This is very labor and resource intensive for that facility, and so often these facilities would like results as soon as possible in order to remove those airborne precautions from those individuals. So if it takes 2 days to get a specimen to the State Public Health Lab and that individual is very sick, keeping them in airborne isolation precautions for that lengthy period of time may not be optimal. And so we may need to look at other alternative methods for getting specimens to the State Public Health Lab, whether that's asking for the hospital to provide a courier or the local health department to provide assistance to get the specimens to the State Public Health Lab. So the clinical management of these patients, again, is mostly supportive care. Again, standard contact and airborne precautions should be implemented upon suspicion, whether that be in the emergency room or once they're actually hospitalized. I also want to point out that hospitalization is not required. There are often people who have fever and pneumonia who have traveled to these countries who are not ill enough to be hospitalized. If hospitalization is not required, there are guidance documents that can be provided to the patient to ensure that they can provide themselves home care. Again, if they're clinically well, they should be discharged home. And at this point, the state and local health departments should be involved of maintaining routine contact with this individual and their contacts to be sure, A, that they're both staying at home and that they continue to progress with a good clinical status. So as far as facilities, again, it's important to remember to implement measures to quickly identify suspect cases and prevent additional transmission, particularly within those healthcare centers, since we know that they are problematic. This would include the monitoring of staff and patients and visitors that may have come in contact with those cases. And so this is a call to facilities who may be on the line, or if local health departments are working with facilities, to remember and to remind yourself that they will be asked to monitor their staff for signs and symptoms, and they should be prepared to do that quickly. This will include asymptomatic workers with unprotected exposure to any MERS patient will be asked to be excluded from work for 14 days. This is actually an additional guidance that has been added to the new CDC guidance document, and clearly this particular guidance can produce significant impact to the facilities that may have had confirmed MERS cases within their facility. So these are some things that facilities should really think about how they might implement. Finally, the impact of the local health department. Again, we'd work with you to gather case information, complete or assist with the person under investigation form. And a lot of people ask why this is required even if the case goes into CDRSS. The person under investigation form is required for any case of the State Public Health Laboratory tests. That's because the test is actually being done under emergency use authorization, and so those particular test results must have that form attached in order for us to be able to report the results of that test. So I understand that it's a little bit of double work, but we do require the PUI form be completed. Again, the assisting the facility with specimen transport. If there is a patient discharged home and patient management and exposed contacts are being stayed home, for the local health department to maintain contact with those individuals to make sure that things are going well. And that's all the slides I have, and I'll take any questions if there are any.
Okay, thanks, Lisa. Again, if you have questions, please go ahead and type them into the question box. I don't see any questions right now. so with that, I will turn it over to Kristen Innes. We're going to have 3 more brief updates. Kristen is going to talk briefly about rabies, and Shireen will talk about Ebola and Lassa fever, and Diana will sort of follow up on the Lassa fever and talk about some community contact tracing. Before we turn that over, we did have one question. Lisa, let me expand the box here. The question is, can they submit a sample via courier?
Yeah, the samples can be submitted via courier. That's absolutely true. Again, a word of caution is that when specimens come from the courier, while the courier picks up specimens at 7:30 or 8 o'clock in the morning, they don't often arrive at the state public health lab until 3 or 4 in the afternoon. So in those particular cases, sometimes if it's a non-priority specimen or a low-priority specimen, that specimen will be tested the following business day. Again, so that's where the judgment calls on the same-day testing or not. Also, a word of caution is that the courier doesn't stop each and every day in every location. So if you had a courier stop on Monday and the case is called in on a Thursday, it's often not optimal to wait until the following Monday for the courier to actually pick up that specimen and deliver to the public health lab. So it's just a thought process that you can certainly use the courier system that's managed by the state public health lab, but there has to sometimes be that it doesn't always fit the bill, and there may be alternative methods that may be needed to be employed in order to get that specimen to the state public health lab.
All right, thank you. Also a question about if you know why there tends to be hospital shopping in Korea?
I'm not really sure why there tends to be hospital shopping in Korea, but I do understand that it is part of their culture. I don't know if it's a payment-based system or if they're just looking for the best actual physician. It's my understanding that they tend to go to multiple different doctors and multiple different facilities before they actually settle on one particular healthcare provider that cares for that individual. I think as we see the closure of the Korea outbreak, hopefully we'll actually begin to see a little bit more information coming out of the Republic of Korea that may help document and explain some of this so that we can get a better understanding of what's actually happened here in this outbreak.
Okay, thank you. We don't have any additional questions now, so I'm going to go ahead and turn it over to Kristen. If you do have additional questions, again, go ahead and type them in, and we'll get to them at the end.
Okay, hello. I'm Kristen Innes. I'm a zoonotic disease epidemiologist here at the State Health Department. Today I'm going to just provide an overview, just going over the process of identifying rabies exposures, submitting the specimens. We are going to speak a good amount about using the state courier and when that is best. So excellent question to whoever submitted that before. We're going to go into that a little more deeply. And also the process of notifying everyone involved with a rabies investigation of the actual test results. And I'll also touch briefly just about the importance of providing outreach to some of your public health partners in order to make these rabies investigations and follow-up go a little more smoothly. Okay, so I have presented at these CD forums multiple times, and one thing I always include in my presentations is the definition of rabies exposure. So by now you probably know there are 2 different main types of rabies exposures, the bite and non-bite exposures. So a bite exposure, which is actual penetration of the skin by the teeth from those potentially rabid animals. Those high-risk animals are your skunk, fox, bat, groundhog, those types of animals. And then we have non-bite exposures. So those would be scratches, abrasions, open wounds. Those are ones that bleed within 24 hours. I know sometimes there is some question of whether a wound is actually opened or not, or contamination of mucous membranes such as the eyes with saliva or other potentially infectious material from a potentially rabid animal. And so it's very important to understand and know these definitions as we base our public health response off of it. If an exposure did not occur by using these definitions, testing of the animal or the need for post-exposure prophylaxis would not be indicated. When dealing with bat exposures, the definition is slightly different. A bat exposure is, again, it can be the bite from a bat, so penetration of the skin by teeth, or again, saliva contact or brain and spinal cord tissue that goes into open wounds, mucous membranes such as the eyes. However, that is less likely. Usually, if you are getting exposed from a bat, it will usually be via bite, since they do have such little saliva. But bat bites are less severe and more difficult to recognize than bites inflicted by other larger animals, such as your raccoons or your skunks. So it's really important to properly assess possible bat exposures. Other situations where a physician might recommend post-exposure prophylaxis could be finding a bat in the house with a person who may not be aware if a bite or direct contact did occur. So this could be someone who's deeply sleeping, who awakens to find a bat in the room, and they're not sure if they might have been touched by the bat or if they had any type of direct contact. Or it could be an adult walking into a child's nursery and there is a bat in the room. They didn't hear the child cry, but the child may not have even known that the bat was there, or just didn't wake up from being touched by the bat. So these situations should not be considered exposures if laboratory testing of the bat has ruled out infection or circumstances suggest that it's unlikely that an exposure took place. So with situations with bat, it is really important to capture the bat safely and test it for rabies, as there are some of these gray areas in exposure definitions where there may be some real concern that a person may not have woken up with after finding a bat in the house, in the bedroom. So at the last CD forum, I discussed different ways to deliver specimens to the rabies laboratory. I went through that you could use a state courier, private courier. You could drop it off yourself, anyone from the local health department, any public member. So today I'm just going to focus on using the state courier to transport your specimens. This is a good way to transport your low-risk specimens to the rabies laboratory. So you should be aware of where the nearest location is and its scheduled pickup time. Sometimes we receive calls asking, why didn't I receive my rabies results? You know, it's been 3 to 4 days. Where's my rabies results? That's abnormal. Usually the answer is maybe it did not reach the courier in time for the pickup. So you want to make sure that you do get your specimen to the location before its pickup time. If your specimen did not arrive at the lab as expected, you're going to want to contact that courier location and ensure that the specimen was collected and delivered to the rabies laboratory. Not getting a specimen to the courier location at its pickup time, before its pickup time, can lead to delayed test results. And sometimes that will hit over a weekend, and then you don't get test results till the following week. We know when dealing with these rabies exposures, the public that has been affected by this suspect rabid animal may call you numerous times trying to get that result. So we definitely want to try to get the specimen to the lab as soon as possible. Specimens sent by the courier usually will be accessioned the next day, the next working day, with the results reported to the health officer the second working day after it's received by the lab. So when using the couriers, if possible, it's best to submit specimens between Monday and Wednesday in order to get those results before the weekend. If the specimen requires priority testing, that needs to be requested by the health officer. And I also just would like to note that high-risk animals, such as bats that bite people, that should be delivered directly to the rabies laboratory. And these courier services should not be used in those high-risk situations, as we do need results as soon as possible, especially with high-risk animals and direct bites. So notification of the test result. Once the rabies lab has a test result, the general process of relaying the information to all the individuals involved It can be quite lengthy, but it's very important. So once we have a test result, all test results, whether it's positive, negative, or unsatisfactory, as sometimes we do see, especially with bats, are back to the local health department directly from the rabies laboratory. The rabies laboratory also calls us here at the state health department and notifies us of any positive and unsatisfactory results that are going to need public health follow-up, whether it be confinement of an animal or post-exposure prophylaxis. Just doing our due diligence, then here at the state health department, we call the local health department just to confirm that they did receive that fax from the rabies lab. And then we're also there on the phone to help assist in identification of exposed persons or domestic animals that may not have been first thought upon in the beginning of the investigation. The local health department then should notify all parties available in the exposure. Sometimes this is multiple families. Perhaps it is a dog that was bit by a raccoon on someone else's property who also has a dog that may have been exposed. So sometimes you do need to contact many people, but it is very important to do so. And as I said before, this may include doing some more investigation than was originally done when you first received the call of the suspect rabid animal. So you may need to identify other individuals and pets who may have had contact with this animal. And I'd just like to note that the New Jersey Department of Agriculture handles the follow-up on exposed wild stock that are exposed to suspect or rabid animals, such as a rabid fox getting into a stable with horses. Okay. Now I'm just going to talk a little bit about the importance of providing outreach to some of your public health partners. You're going to want to make sure that you provide your after-hours contact information to animal control officers, your veterinarians in your around your jurisdiction, emergency departments, and physicians, so they can report and respond to rabies exposures that they see in their office. If you notice an increase of calls regarding certain providers or on specific topics, I recommend you provide education to that facility. For example, let's say a veterinarian's office calls constantly regarding dogs coming in the office with wounds of unknown origin, and do they need to administer a booster? What do I do? Is it an observation or is it a confinement period? Do I need to report this to you? All this information is in our guidance document, Management of Domestic Animals Exposures, but instead of just sending them to the website and say, here's the information, figure it out on your own, it might be nice to just kind of assess what is confusing them about this guidance document. Maybe someone from your office could go in and do a training reviewing the different exposure categories and what is actually needed by the vet, what needs to be reported and what does not need to be reported. And then while you're at it, you might as well go in, and we know sometimes we get complaints from veterinarians about having to revaccinate animals to line up with dog licensing period. Then you have them in the office to kind of go over that as well, another great topic to review. So not only will this benefit them by equipping them with the guidance that they need to respond to these rabies exposures, hopefully it will help decrease the load of calls coming into your local health department, since they now have this knowledge and can do it on their own. So the New Jersey Department of Health has a lot of great thorough guidance documents, so be sure to share them with your public health partners. These are the ones that were relevant to today's presentation, specifically bat guidance and the specimen submission document and the guide to post-exposure prophylaxis.
Okay, thank you, Kristen. We have a couple questions and also one comment. Someone suggests adding police departments to constituent outreach in terms of after-hours contact information, so that's a good suggestion. And a couple questions in terms of one on specimens. So the question is, are any specimens received or accepted on Thursdays and Fridays at the public health lab?
Yes, they can be received, but the public health lab, they actually can also be received on weekends. You can drop off specimens 24/7. For these, when using the state courier, we do recommend Monday through Wednesday if you want that result before the weekend, as the accession of the specimen doesn't happen until the day after it is received when it comes from a courier, and then the test will take an additional day.
Okay. And how receptive have you found physicians to be for providing prophylaxis to exposed individuals who wake up finding a bat in the room?
We do receive a good number of calls from healthcare providers looking for guidance on what to do. Usually, once we go over these definitions, ultimately it is the physician's responsibility to make that decision on their own on whether or not to provide post-exposure prophylaxis. And I do feel that these healthcare providers would rather provide the post-exposure prophylaxis if they feel there is a true risk.
Okay, great. Thank you, Kristen. At this point, I'm going to turn it over to Shireen Temple, and she's going to give a brief overview about some Ebola updates and an investigation that was conducted with Lassa fever.
Thanks, Kim. Hi, everybody. My name is Shireen Semple, and I'm the Vector-Borne Disease Program Coordinator. I'm also the subject matter expert and overall lead for viral hemorrhagic fevers, including Ebola and Lassa. As we approach 1 year since August 1st, 2014, when the CDC declared a level 1 escalated response to the Ebola outbreak in West Africa, I'd like to take a moment to share our surveillance efforts and review our current protocols. Thanks in large part to the great work from local health departments, New Jersey has been successfully monitoring persons for Ebola virus disease, or EVD, for almost 10 months now. Since enhanced entry screening was first implemented in mid-October of 2014, over 1,000 travelers entering the U.S. from EVD-affected countries have been reported to the New Jersey Department of Health. Of the travelers reported to New Jersey Department of Health, the overwhelming majority have been from Liberia. On May 9, 2015, the World Health Organization declared Liberia Ebola-free following the completion of 2 incubation periods with no new cases. And on June 17th, the New Jersey Department of Health modified its active monitoring protocol for travelers from Liberia in response to modified recommendations from the CDC. The modified recommendations allow that all travelers from Liberia, both current and new, are no longer subject to active monitoring by public health officials, and instead are asked to self-observe their health status for the 21-day incubation period following departure from Liberia. Although there was a confirmed case of EVD in late June in Liberia, and the strain did match the one previously circulating in Liberia, and thus was not likely to have been imported, the contacts of that case were closely monitored, and transmission was not considered widespread. As such, the modified protocol has not been impacted. But even with the modified protocol, we continue to monitor persons from countries where widespread transmission continues and the risk of EVD is still present, including Sierra Leone and Guinea. Since active monitoring began on August 27, 2014, local health departments in New Jersey have monitored over 1,200 persons, with nearly 50% of those persons residing or staying in 3 counties, including Essex, Mercer, and Burlington. Since August 2, 2014, there have been over 25 persons under investigation, or PUIs, for febrile illness possibly compatible with EVD. All but one of these persons have been in the low but not zero risk category for EVD, although only a third had been under active monitoring in New Jersey. Of these persons, a little less than half had been evaluated at one of New Jersey's EVD assessment facilities, underscoring the importance of frontline hospitals maintaining preparedness for EVD. No cases of EVD have been identified in New Jersey, and only one elevated risk PUI was actually tested for the virus. Instead, the vast majority of PUIs are tested for more likely illnesses associated with fever and travel. Looking at hospital discharge status for PUIs evaluated in New Jersey, of those with a final diagnosis, malaria was the most frequent cause of symptoms. Overall, most PUIs do not have a final diagnosis and instead were discharged from the hospital after symptoms improved, since clinical improvement is something that would not occur with EBD. As most of you know, New Jersey confirmed a case of Lassa fever in May. This is the 6th case of Lassa fever in the U.S. since the virus was first described in 1969, and the 2nd case in New Jersey. The first was identified in 2004. Lassa fever is an arenavirus and a viral hemorrhagic fever, meaning it's zoonotic and primarily restricted to geographic areas where the animal host is found, which includes West Africa and primarily the countries of Sierra Leone, Liberia, Guinea, and Nigeria. The reservoir for Lassa virus is the rat. Rats shed the virus in urine and droppings, and direct contact with these materials through touching soiled objects, eating contaminated food, or exposure of urine and droppings to open cuts or sores can lead to infection. Lassa virus may also be transmitted person to person through unprotected direct exposure to blood, tissue, secretions, or excretions of a Lassa virus-infected individual. However, this method of transmission occurs far less frequently. Casual contact, including skin-to-skin contact without exchange of body fluids, does not spread Lassa virus. Areas of West Africa where the virus is endemic see approximately 100,000 to 300,000 cases per year, and approximately 5,000 or 1% of these cases result in death. Symptoms of Lassa fever begin 1 to 3 weeks following exposure and may be prolonged or mild. Mild cases may not even be detected. Symptoms may include fever, sore throat, malaise, headache, and weakness. More severe symptoms may include hemorrhaging, respiratory distress, repeated vomiting, and shock. Ribavirin, an antiviral drug, has shown some success in treating cases when given early and administered via IV. On May 17th, later in the evening, a traveler arrived from Liberia through JFK. As per routine enhanced entry screening and active monitoring for Ebola, contact information for the traveler was reported to the local health department early on May 18th. The local health department attempted to initiate active monitoring with the traveler on that same day, but was not able to reach the traveler until May 19th, following a conversation with the traveler's emergency contact. Once the local health department started active monitoring on May 19th, the traveler reported non-elevated temps on May 19th, May 20th, and May 21st. On May 22nd, the traveler did not report his daily temp until early evening, when he called the local health department to report that he was in the hospital for a fever and sore throat. At this point, the local health department immediately notified the New Jersey Department of Health Communicable Disease Service. That night, CDS had a conference call with the hospital, which I'll call Hospital A, and the CDC, and learned the following. The traveler had been in Liberia for 3 months, working in a rural area, where he reported noticing a rat problem in his work camp. His symptoms started in Liberia and included a fever and sore throat. After returning to the U.S. on May 17th, he went to the emergency room at Hospital A on May 18th, complaining of the fever and sore throat. He was not admitted to the hospital, but as symptoms continued, he then went to his primary medical doctor on May 19th. And by May 21st, when symptoms persisted, he went back to Hospital A and, at this time, was admitted through the ER to the facility. Hospital A reported at both visits to the ER the patient did not reveal travel to Liberia. During the conference call with the CDC, symptoms were reported as the fever, sore throat, and elevated liver transaminase. It was decided the traveler was low risk for Ebola, given the lack of cases in Liberia and prolonged clinical presentation, but possibly at risk for another viral hemorrhagic fever, such as Lassa. The traveler remained in isolation, and a decision was made to conduct additional blood work and observe the patient overnight. On May 23rd, the Communicable Disease Service, Hospital A, and the CDC had another conference call in the morning. At this time, we learned the patient's liver function was rapidly declining, and a decision was made to test for Lassa virus and transfer the patient to an EVD assessment facility, which I'll call Hospital B, for a higher level of biocontainment. CDS worked with Hospital A and the CDC to arrange transport of the specimen, which was driven overnight from New Jersey to Atlanta. On May 24th, the patient's condition deteriorated and wet symptoms began. The patient was intubated and transferred to Hospital B's extended treatment area, which is a specialized unit for management of viral hemorrhagic fevers. Shortly after midnight on May 25th, we received confirmation of Lassa virus from the CDC and formed a Lassa fever response team to conduct contact tracing and monitoring. Sadly, later in the day on May 25th, the patient expired. On May 26th, the CDF and the CDC began contact tracing and site visits to hospitals A and B. On May 30th, 2 post-exposure prophylaxis clinics for high-risk contacts were held, one each by Hospital B and the local health department. Contacts were followed for 21 days, or the maximum incubation period following the last potential direct exposure to the patient. During contact tracing, 1 high-risk contact reported symptoms on 2 separate occasions and was tested for Lassa virus. Fortunately, the contact tested negative. The investigation concluded on June 19th when the last contact completed their monitoring period. As with the Lassa fever case in New Jersey in 2004, no secondary cases were identified. Now I'll briefly describe the overall public health response, and Diana will share more specifics about the community investigation. The CDS Lassa fever response team included several branches structured in the same manner as the incident command system, including branches for epidemiology and monitoring, clinical evaluation and management, health education and risk communication, a laboratory liaison, and logistical support. In addition, the New Jersey Department of Health requested CDC assistance for investigation of the hospital contacts and procedures. As such, a CDC CERT team was sent from May 26th to the 31st, where subject matter experts from the CDC in viral hemorrhagic fever, infection control, laboratory practices, and NIOSH provided technical expertise in the investigation. Other partners included the Newark Department of Health and Human Services, administration and support from hospitals A and B, a commercial lab in New Jersey where a specimen had been sent for routine testing prior to suspicion for Lassa fever, the Associated Send-Out Lab and their state health department, Essex Regional Health Commission and other local health departments where community contacts resided, and the CDC Division of Global Migration and Quarantine, who coordinated the notification and monitoring of persons potentially exposed during the flight from Liberia to the U.S. The goal of the EPI investigation was to identify contacts and then classify these contacts based on a risk survey into 3 levels of risk, including no risk, low risk, or high risk. The risk levels were determined according to potential exposure to the patient, blood and other body fluids, or contaminated objects. The EPI and response team was tasked with monitoring symptoms of these contacts, again for the 21-day incubation period, and movement associated with contacts if the movement was restricted. Again, Diana will go into more detail in this area. The EPI team also generated daily situation reports, or SIT reps, which detailed the status of the various contacts and potential persons under investigation, or PUIs. There were 4 regional epidemiologists assigned to the contact populations, and the regional epidemiology program provided a lot of support to this investigation. These 4 contacts, 1 each was assigned to Hospital A and Hospital B, and then 2 regional EPIs were assigned to oversee community investigation. And again, Diana was one of those and will provide a detailed description of what occurred there. In conclusion, we had a total of 213 contacts that were identified through the contact tracing. And that included 33 persons that were determined to be of no risk, 162 persons that met the definition for low risk, and then 15 high-risk persons, one of which was from Hospital B and the rest from the community. Although we had no secondary cases identified in this investigation, we learned a few important lessons, and I'll just briefly mention two important points. One was that we want to continue to work with our hospitals and healthcare providers to emphasize the importance of always taking a careful travel and risk history on all persons to rapidly identify, isolate, and respond to any cases of viral hemorrhagic fever, not just Ebola, but including other viral hemorrhagic fevers such as Lassa that may be endemic to areas of West Africa or Africa and other places, and even other diseases such as MERS-CoV and other emerging pathogens. We also learned the importance and the continued importance of engaging partners in public health and healthcare to work together to reduce the stigma of Ebola in travelers, so we can encourage individuals to be more likely to report travel history and symptoms in a timely manner. And with that, I'm going to conclude the presentation, take any questions, and then turn it over to Diana for more detail.
All right, thanks, Shireen. Just one question right now concerning, I guess, exposure with rat droppings, and asking if someone was in a cave in Liberia, if that would be a likely exposure.
Sure. For viral hemorrhagic fever in general, getting a careful travel history, and if a person was in a rural area, knowing if they've been in a cave or any other place can shed a lot of light on potential symptoms and clinical course. Lassa fever, for example, can present in this mild and prolonged manner. So getting that careful history in this situation of potential exposure in a rural area to rat droppings was very important. And so certainly being in a cave can shed light on not only Lassa but other potential pathogens that may be transmitted by rodents or even bats. There are also seasonal patterns to a lot of the viral hemorrhagic fevers. For example, with Lassa fever, the time of risk is primarily heightened from December to June, and then decreases a bit when the rainy season begins, and quite frankly, folks are not outdoors as frequently because of the rainy season. So getting that time and specific exposure history is critical to honing in on what may be at play.
Okay, one other question. The arrival of the CDC 13, was that an automatic procedure related to the diagnosis, or was that a special request from the State Department of Health?
That was a special request.
Okay. All right. So with that, we're going to turn it over to Diana. Again, we can take more questions at the end.
Good morning, everyone. My name is Diana Terrio. I'm the regional epidemiologist in the Northeast. I'm going to kind of give you a brief overview of community contact tracing and monitoring, and give you sort of the behind the scenes at the local health department, you know, key responsibilities, what we worked on, challenges, and lessons learned. So for community contact and tracing, we worked with the Newark Health Department. They established a local response team, and that included the health officer, health director, health education staff, nurses, and investigators. So my presentation basically goes through the key responsibilities of identifying close contacts, survey administration, risk assessment, daily symptom monitoring, data management, and discuss a little bit about identifying community leaders and educators. Like Shireen said, we had 2 regional epidemiologists that were on site with Newark Health Department working on these key responsibilities. So as you can see, there's a questionnaire that was developed by the Lassa team. There's a picture of the first page that includes information on demographics, specific information on when you had contact, or when the person had contact with the case, and what type of contact. So the questionnaire goes in depth. There's a few more pages about the type of contact and if there was PPE involved with that contact. So the standard questionnaire was developed and used on contacts involved in the community. Most of these were family contacts, as we learned that the case had a large extended family. And we did identify 37 potential contacts. So going into information on high risk and low risk, as Shireen discussed briefly, we determined that there were several high-risk contacts in the family. They did have several healthcare workers in their family, and so they were caring for him while he was ill. So I'm just going to go through this real quickly. High risk is defined as direct, unprotected contact with infectious materials, such as blood and body fluids. So basically, we monitor everyone for 21 days, but the difference between high risk and low risk is that the high risk individuals are directly observed, which means that the local health department would visit each person at their home, or they would use Skype or FaceTime to monitor them while they take their temperature. So high-risk contacts also have some restrictions. Young children were excluded from school or daycare, and the reason why this is because children are unable to fully communicate signs or symptoms of disease. So if they do get sick while they were there, then they may not be able to fully communicate that to their teacher or nurse or whoever is there. So older children and adults have no restrictions on activities for work or school. However, they do have restrictions on public conveyances, and we're restricted from taking planes, trains, or buses. They were allowed to use personal vehicles. However, the Department of Homeland Security did issue do not board letters to all high-risk travelers. Out-of-state travel in personal vehicles was allowed, but we do want any contacts to notify the local health department, and so then we can notify the other state of where they're traveling ahead of time. So low-risk exposure is casual contact with a case or protected close contact with blood or bodily fluids. So in the hospital setting, there were a lot of low-risk exposures because the physicians use PPE when caring for the patient. Again, all contacts classified as high or low risk were monitored for 21 days. Low-risk contacts took their temperatures twice daily and reported those temperatures once daily. However, they were able to report them by phone, text, or email. They didn't have to have a specific site visit or on Skype. So again, low-risk exposures were also excluded from daycare settings for the same reasons, unable to communicate that information to an adult. No other restrictions were placed on low-risk individuals. However, it is important for any travelers, as I said, to communicate this with the local health department ahead of time. There are some states that do want to monitor, such as Florida. When they receive anybody, they actually do direct active monitoring. Okay, so risk classifications, there were 37 total community contacts, 14 high risk, 13 low risk, 9 no known risk, and 1 refused interview. However, they did state that there was no contact, and that's why they didn't want to speak with us. So Newark Health Department and Essex Regional Health Commission did go to the family homes to conduct the interviews with the potential contacts. 27 contacts were then classified into high and low risk and monitored for 21 days since their last exposure with the case. Additionally, Newark Health Department worked with their on-site clinic to offer PEP and counseling for high-risk contacts, although all of them declined when offered. So as stated previously, contacts monitored temperatures twice a day. They had to report to the local health department once daily, and some community contacts at times were reluctant to provide temperatures as requested. at this time, then a home visit was made, even if they were low risk, by a nurse to gather that information. So data management. As you can imagine, we gathered a lot of information, so it's important to organize the information to keep track. Community members that were determined to be of any risk were entered into CVRSS. So as a new case, as we've done in the past for travelers coming from Ebola, we entered them in as a brand new case and would follow them for those 21 days, entering the temperatures in daily. Not all contacts lived in the same jurisdiction, so when it was reported where they lived, the regional epidemiologist would then notify the local health department where that person resides. So at that point, Newark Health Department did continue to monitor all contacts. It did seem to be the easiest thing to do. Temperature readings were entered by Newark Health Department, and then the regional epidemiologist would actually monitor that and enter the data into a spreadsheet. So the spreadsheet included all contacts where they had missing temperatures. The spreadsheet then was shared with the local health department, which it just seemed to be the easiest way to determine any missing temperatures that were needed to be followed up on. So any issues contacting them would be then brought back to the loss of response team at the State Health Department, and at the end of the 21 days, the case would be closed out and approved. So Shereen mentioned there was one community contact member that did become ill 2 times during the incubation period. No secondary cases were eventually identified. As she said, it did turn out to be negative tests. However, this individual was considered high risk and was hospitalized in response to the symptoms she experienced. The first time, she complained of heavy eyes, back pain, and swelling on day 7 of monitoring. At this time, she had a low-grade fever that was hovering around 99, and since we don't really use we use a cutoff of 100.4 or for loss of fever, then we didn't really consider this a high risk, but since it was coupled with these symptoms, we then did want to test her. So she was admitted to the hospital, and testing was completed at CDC. The test was drawn at the hospital and then was driven actually down to Atlanta. The test was completed within about 24 hours and was determined to be negative. The contact was then released and sent home. So she had a couple days at home where she was feeling fine and then again became symptomatic. This was actually on day 20 of the monitoring period, so day 21 is our last day. She was almost there, but started having symptoms of headache and tonsillitis while working in Morris County. She also had a fever at that time. So the contact started feeling unwell while she was at work and visited her occupational health center at her place of employment. In consultation with New Jersey Department of Health and CDC, the contact was then determined to need evaluation at the hospital. The logistics of moving the individual from the workplace to the hospital proved to be a little more difficult than originally anticipated, as there was a delay in transport while EMTs made preparation. The contact was then again tested for Lassa and determined to be negative. So some challenges while working on this investigation. Initially there was a large group of people that had to be identified and interviewed, and unfortunately, since the case passed away, he was unable to provide some of the information that we would have needed about what activities were conducted in the days prior while he was symptomatic. So thorough interviews were conducted with family members individually to gather information on those activities and when they occurred, and determine who else might have been exposed. However, some contacts were resistant or hesitant to provide information, wanting to protect the case, and also, while under active monitoring, hesitant to provide some information on temperatures and symptoms because they did not want to be the first one in the family to become ill. We did learn that there's a stigma facing those from traveling from West Africa to the United States, and that the case and others may omit information when coming into the country, so they're not quarantined or isolated from the community. Additional challenges were posed when the burial of the case happened. There are some religious practices in cleaning the body before the burial. However, this would have been a risk to those handling the body and therefore was not appropriate in this case. However, it's important to be sensitive, obviously, to the concerns of the family and the religious concerns. So you can see here there's a little flyer that Newark Health Department put out to bring some people into a workshop, better educate the community. So community health meetings were held in the past for Ebola, so that rapport was developed already and the relationship was there with this community. So in addition, in response to this case, Newark Health Department held a meeting with the family and local religious leaders that the family trusted. So this helped in communications with the important messages as a trusted partner. Also, while interviewing family members, we learned that there was a doctor in the family, so or a third-year resident. So this person wanted to be the main contact for the family, which worked out perfectly for us when communicating with a large extended family to help with some of the logistics and to help with some of the sensitivities to family concerns. We listened to what she said and took that in. So some of our lessons learned here were, you know, having that established relationship with the community in advance, you know, people that you're serving and leaders of the community. It helps when there's some sort of emergent situation, you already have that established relationship and built-in trust. We also learned that there's a stigma to be aware of in the West African community, and in order to prevent delayed diagnosis and hesitancy to provide complete information, we do need to be aware of that. Protocols that were put in place for Ebola active monitoring actually assisted with the facilitation of the loss of response, including the active monitoring of contacts, the logistics in dealing with symptomatic individuals, and also having a non-compliance document. Lastly, it's essential to have a collaboration between agencies like New Jersey Department of Health, the local health departments, and CDC in order to facilitate that coordinated response. So without collaboration of so many partners, this wouldn't have been possible. So I especially want to thank Newark Health Department, did a wonderful job, and our Regional Health Commission in Essex, Morris County Office of Health Management, Livingston Health Department, and all other local health departments involved in the community contacts. Additionally, the community leaders in Newark were crucial in this investigation. I'd like to say thanks CDC and also my team here at New Jersey Department of Health.
Thank you, Diana. Two questions came in about LHSA. Shireen, I think these probably go to you. One is on what is the appropriate post-exposure prophylaxis for LHSA fever, and secondly, since we were using an incident command system, who was serving as the incident commander in this case?
Okay, thanks. So using the incident command system, the incident commander in the LHSA situation, as is most situations for our communicable disease services, Dr. Tina Tan, our state epidemiologist and assistant commissioner. And then, for example, I was the overall lead, but then we had team leads for each of the branches. So again, for example, under the epidemiology team, Lindsay Hamilton, our CFTE fellow, was the lead there. So, and then moving on to the second question about the post-exposure prophylaxis. For LHSA, oral ribavirin is the PEP. It's not really a cut and dry decision, though, because there's limited data on whether this is effective. So, for example, there have been situations where folks have taken oral ribavirin, but whether they didn't develop LHSA because of the ribavirin or because secondary cases are not as likely, especially when you compare it to a viral hemorrhagic fever like Ebola. Again, we don't have any conclusive data there. Also, with something like oral ribavirin, the sooner it's taken, the better, and it does have to sort of accumulate in the body according to the person's weight, et cetera, to potentially be effective. So when you have an exposure that is not overt, maybe a high-risk exposure due to, let's say, a lack of PPE rather than an overt splash or puncture, the decision to take the post-exposure prophylaxis, especially a few days or a week out, is kind of a difficult decision because the medication is not without its cons. So that may have contributed to the lack of any folks taking PEP.
Okay, thanks, Shireen. Rebecca, we had a question if you have any information on the recent Bronx Legionella outbreak.
Sure, I have a little bit of information on that. So currently, right now, in the South Bronx part of New York City, they're experiencing a large uptick in cases. So right now, the last I've heard, there was 31 cases of Legionnaire's disease, including 2 deaths. So as a reminder, this is not a person-to-person spread, so to see that many cases in a short amount of time is a lot. So they're looking at this area of the Southern Bronx. There's a large co-op city complex there, apparently. They're also looking into the cooling tower there. My understanding is that the cause has not been determined yet, and the clustering has not been seen in a single building or a single workplace. I do ask, though, being neighbors to that area, that all Legionnaires cases that are put in CDRSS for New Jersey residents, it's another reminder, but please put a little magnifying glass under these cases to inquire about work, visit, and travel to the South Bronx during their incubation period. And if you do detect any cases that mention that exposure, please let me know, and we need to get that information back to New York City. Thanks.
Thanks, Rebecca. And another question for Lisa. I believe this is on MERS. If you could elaborate a little bit more on the asymptomatic healthcare workers who have had unprotected exposure and the exclusion from work for 14 days.
Sure. So because this has been predominantly associated with healthcare facilities, those individuals who have had unprotected exposures to a confirmed MERS case have the potential of they themselves becoming ill and subsequently spreading it within the healthcare facility. And so that's the understanding of why that type of recommendation is being made from the CDC. So again, similar to what you've been doing for Ebola and Lassa fever, during these types of investigations, we would evaluate different types of risk exposures on these individuals who may have come in contact with a confirmed MERS case, and those individuals will be placed in different categories with different restrictions on their activities, as well as different types of monitoring. CDC is in the process of working on a very specific guidance document associated with that, and we expect that to be available in the upcoming weeks.
All right, thank you, Lisa. So I see no more questions. So just very briefly, I did want to mention that Barb Carruthers, who is our school and daycare subject matter expert, has developed some new educational materials on Staph disease, which may not be as exciting as MERS and Legionella, but it is a very common occurrence in daycare and school settings. So we did want to bring this to your attention that there is a new FAQ as well as an exposure notice, which is something that the daycare facility can post for parents, and I included the link for that at the bottom of the page. And here we go. A couple upcoming training opportunities. The first one is the Northeast Epidemiology Conference. There is a cost associated with this. It's about $225, I think. It's at the end of September. This is a conference that includes all of the Northeast states, so basically from New Jersey, Pennsylvania, up to Maine. I have the website here. It'll be located in New Brunswick if you're interested in that. And we will be continuing with our in-person forums in the fall, probably October, November, and I'll send out a save the date for that when we have those dates and locations. And wrapping up for where are my slides going? For evaluation and credits, anyone attending the webinar will receive an evaluation link. If you physically are registered on GoToWebinar under your name, you will be counted as attended. If you are watching the webinar as part of a group and your login is not used, then I will need a group sign-in sheet. So it can be very simple. It can even be handwritten. I'm fine with that. Just have the name of the forum, today's date, July 30th, each participant's name and signature, organization obviously, and your NJLMN email address. And you can either fax that to me or you can scan it and email it to me, and then I will mark you off as attended, and then you all will get the evaluation link. The evaluation will be up for about a week, and if you are receiving public health credits, they will appear automatically on your transcript in NGLMN. For nurses, you must remember to include in that online evaluation your name and email address, because that's where we will email your nursing contact hour certificate. Let's see, and with that, as a reminder, the program is recorded and it will be posted on the website that I showed at the beginning on the Communicable Disease page under CDS Training Resources. And with that, I think that's it, and I appreciate your time this morning, and I hope this was useful. And again, if you have any other questions or comments, certainly feel free to either call me or send me an email. And with that, thank you very much.